And I am going to just give everybody another minute or so to join before we start. So please just stay tuned. To introduce box at the bottom. Yes, we can hear you.
Yeah, we're having trouble hearing your audio.
All right, I'll just turn off the video. Okay.
I think you should start again.
Let me know. Okay, we will start again. So good morning, good afternoon, and good evening. I'm very happy to welcome you all to today's ICAP conference, where we will be looking at, and I have 3 speakers to introduce. And after that, we will get started with the presentation. And we'll, as usual, have our Q&A session, questions and answer session. And please put your questions and answers in the chat box. I'm sorry, is this audio really not going to work? Hello?
Jessica, I'm afraid we're still having trouble hearing you. You seem to have a bandwidth problem.
I'm going to close some applications on my computer. Let's try that. That's my apologies for the delay here. I thought we were in. Close a few more things. You can imagine I have a lot of things open.
Jessica, do you want me to take over?
Yeah, why don't you take over here so we can keep moving, and I'll just, you know, be able to moderate a little bit later. Thank you so much.
Okay, great. Welcome, everyone. This is Wafa El Sadr. I'm Global Director for ICAP, and it's a great pleasure to have you join us today for this very important webinar. Let me start by introducing the speakers. And let's start first with introducing Oksana Deriviankina. And Oksana is currently serves as the National Coordinator for ICAP in Ukraine. She just joined ICAP maybe about 3 to 4 months ago, and we welcome her to the ICAP family. She has extensive experience in Ukraine, working within the health systems in Ukraine, is a trained epidemiologist with extensive experience in practical experience, in particular, focused on strengthening public health. And then after Oksana speaks briefly to give an update on the situation in Ukraine, it will be followed then by two speakers. We're very happy to welcome two speakers from the International Rescue Committee, IRC, and these include Elizabeth Radin, and she's the Director of Health Policy at IRC, and she works to develop and scale up solutions to public health challenges in fragile and conflict-affected settings. And actually, it's great to see Elizabeth again, because previous to her work at IRC, she was working at ICAP and was a technical director for the Population HIV Impact Assessment Project at ICAP. She's also an epidemiologist by training. Our other speaker to follow Elizabeth will be Seema Jilani. And Seema Jilani is the Senior Technical Advisor, Emergency Health at IRC. And she previously also has been based around the world with IRC in many regions of the world, in Beirut and many, many other countries, and has extensive experience also in various humanitarian settings in other regions and other countries, including Ukraine, Afghanistan, Iraq, West Bank, Gaza, Pakistan, Lebanon, Egypt, and other parts of the world. She completed her medical training, and she is a pediatrician, as her specialty is a pediatrician. So at this point, I'd like to invite Oksana to start with her presentation. Thank you.
Thank you. Dear colleagues, I'd like to start a very brief presentation of what we are doing in ICAP Ukraine, starting with a few slides from the Organization of Humanitarian Coordination Support Agency. We are accumulating figures. We have recently that now we are reporting that almost 7 and 8 million of people looking for the health support program within the Ukraine. And only 5.6 million of this requested are funding by the different local and international NGO. ICAP is contributing to the joint efforts of more than 200 international partners and programs working with the health care cluster. But it's still very, very limited, as I put it here as a number. We are only funding received for around 20% of the health cluster requirements. This is the data based on the July 2023, which is very, very recent, but we are trying to be here on this scale of working on humanitarian response and supporting humanitarian crisis and emergency response in Ukraine. Next slide, please. Talking about the ICAP in Ukraine started her initial work quite recently in the beginning of the year, and focusing on the 5 different streams, which is organized around very critical and very important challenge, which is antimicrobial resistance. Mostly the ICAP is focusing on disease surveillance, including continuous surveillance, syndromic, laboratory-based and event-based surveillance, and environmental surveillance. Next very important step, this is strengthening laboratory system, which is a platform, and upgrading the platform for the several pilots. And then next very important, public health emergency management. All these 4 pillars organized and focusing on finding solution for data modernization, data storage, and data analysis. As ICAP are expert and capacity building expertise, we are mostly focusing on finding the sustainable and long-term program solution for antimicrobial resistant challenge, which is currently very, very important and critical for Ukraine, considering the huge number of wounded soldiers organized all over the different locations in the hospital all over the country. For having this sustainable and long-term support as organizing the capacity building and also surveillance system, we are looking forward to have the very great implementation partners cooperation. And our main partners is the local Ukrainian government, Ministry of Health, Center of Public Health at Ministry of Health, Ukraine, and also 3 regional health facility, regional CDC offices that are working all together, organizing as a multidisciplinary approach to beat and to stream for finding the solution for antimicrobial resistance and working together on the systematic surveillance as well as a laboratory background improvement. Altogether, we are working with international partners here. This is University of Washington International Training, WHO, and some regional international technical projects supporting the activities. Most recently, we have returned from the very interesting, very important step. We are working together with our ICAP expert in Poland, with our local laboratory specialist, working on the understanding how to develop standard operation procedure and how to work closely within the laboratory, epidemiological department, and hospital management. And just next slide, please, want to show you that it was very, very important and very Eastern discussion. And the people was very thankful for having this very important methodology at hand, and they are returning to their hospitals to implement there in this real working environment, how to work on the infection prevention control and surveillance system establishing on the area of the hospital management. So, and we are looking forward to welcome all the people further in October and November events. And we are working closely with them, traveling to the hospitals all over Ukraine, organizing the support wherever we can, and whenever we're supporting also to procurement of laboratory equipment, which will be a very, very important step to continue our focusing on the Recovery Ukraine project efforts in Ukraine. Thank you very much. That's all from my part.
Thank you very much, Oksana. We'll move now to our next presenters, Seema Jelani and Elizabeth Reedy. Welcome.
Thank you so much. Let's go ahead and dive in. Next slide, please. Today, we're going to look at healthcare under fire. So healthcare in public health in areas of conflict. In this presentation, my colleague and I will strive to describe the dynamics of global conflict and the impact on public health, to characterize humanitarian health needs with a focus on Ukraine and Sudan, to highlight two key solutions that the International Rescue Committee has used to deliver emergency health response, both in Ukraine and Sudan, and also to share two longer-term solutions with the potential to improve health in the context of protracted conflict and fragility. We picked these two very different conflicts and contexts, and we'll say more about that in a minute as the presentation develops in order to illustrate a few specific points. And I hope that it'll inspire an engaging discussion after the presentation. Next slide, please. So who is the IRC? The IRC helps people affected by humanitarian crisis, including the climate crisis, to survive, recover, and rebuild their lives. Founded at the call of Albert Einstein in 1933, the IRC is now at work in over 40 crisis-affected countries. We deliver lasting impact by providing healthcare, helping children learn, and empowering individuals and communities to become self-reliant, always seeking to address the inequalities facing women and girls. Over half of the IRC's international work is focused on health. And the following statistics are health-specific statistics where IRC serves population health needs. Through the IRC's work, 3.5 million people have benefited from clean water services, 670,000 children have been treated by community health workers for malaria, diarrhea, or pneumonia, and 29 million people were able to access health services in particular. Next slide, please. We know that violent conflict is on the rise. The United Nations warns that we are seeing the highest number of violent conflicts since World War II. Today, 2 billion people live in settings affected by conflict. In 2022, 79 countries saw an increase in conflict, and deaths from conflict rose 96%. According to IRC's analysis, conflict is driving 80% of humanitarian need. Next slide. So what are the health ramifications on conflict? War often leads to forced displacement and crowded living conditions with barriers to accessing healthcare. This, compounded with a lack of access to hygiene items, can lead to spikes in infectious disease outbreaks. In a context where surveillance has been eroded and hospitals are already overwhelmed, accompanied by impaired vaccine delivery, we see previously eradicated vaccine-preventable diseases may reemerge in conflict-affected areas, as evidenced by an outbreak of polio in the Syrian Arab Republic in 2013. People living in fragile contexts are twice as likely to lack access to safe wash services. One of the most salient examples of this is the 2017 cholera outbreak in Yemen, where there were an estimated 2.5 million cases and 3,868 deaths. And prior to war, cholera had been all but absent from Yemen. Another striking example is October of last year when Lebanon's Ministry of Public Health reported the first cases of cholera documented in the country in 2 decades. For women's health, we know that half of all worldwide maternal deaths between 1998 and 2008 occurred in 6 countries: Nigeria, Pakistan, Afghanistan, Ethiopia, and the Democratic Republic of Congo. All were involved or had been involved in armed conflict. Acknowledging this is an older statistics, we've seen disparities in women's health in fragile settings deepen, and the balance of burden has actually worsened. We know obstruction to family planning and obstetrical services had led to diminished maternal health outcomes, as well as increased of gender-based violence and sexual violence. For children's health, in places where IRC works, we've noted that maternal and child mortality remain up to 5 times higher than global averages, which is striking. We know refugee and migrant children have been shown to have worse health outcomes than residents of the host country, which takes into account outcomes in infectious and chronic diseases as well as mental health conditions. Regarding mental health outcomes, we understand that social breakdown can often lead to unhealthy coping mechanisms, as well as the militarization of society during a conflict. Over 1 in 5 people who have experienced conflict in the previous 10 years will have some form of mental illness, as described here. Attacks on health facilities have grown increasingly common. In 2022, the Safeguarding Health in Conflict Coalition documented almost 2,000 incidents of violence against or obstruction of healthcare in conflicts across 32 countries and territories. That makes for an increase by 45% compared to the prior year and marked the highest annual number since recording began. Next slide. So allow us to dig in to the Sudan context. It's April 15th, 2023. Clashes erupt between the RSF and Sudanese armed forces in Khartoum, resulting in civilian deaths, damage to health infrastructure, regional instability, and looting of facilities, which have rendered the population forced to flee. Keep in mind that Sudan previously had a long record of generously hosting refugees and houses prior to then over 1 million refugees, even prior to the conflict. I'd like to draw your attention to some key demographics of the population in need, notably that the 0 to 17 demographic here is quite significantly high, and 36 and 34% are young boys and girls between the ages of 0 to 17, so a significant portion are of the pediatric and adolescent population. If we're dealing with a younger population in this context, we can consider communicable diseases and malnutrition will be highly represented as a patient diagnosis. Key figures to set our stage are: we have 24 million people in need, 4 million internally displaced since April 15th, over 1 million have crossed borders since then, and only 27% of the funding allocated via the humanitarian response plan has been met. Major health issues in this context are the following. The health crisis is exacerbated by Sudan's pre-existing high morbidity and mortality rates from vaccine-preventable communicable disease outbreaks, including documented dengue fever, measles, and cholera. Now, with the disruption of supply chain and looting of facilities, compounding with the breakdown in disease surveillance, we expect that to increase. The nutrition crisis was already dire prior to the crisis. 3.4 million children under 5 suffer from malnutrition annually, of whom over 600,000 suffer from severe acute malnutrition. Consider this interesting linkage. Between the two otherwise starkly contrasting conflicts, we know that undernutrition in Sudan has been driven both by internal conflict and also reliance on wheat supports, which had been blocked due to the war in Ukraine, further exacerbating food insecurity. Greater than 40% of the population is projected to suffer from acute food insecurity, which is an increase by 74% from last year's projection. Regarding SRH, or sexual reproductive health and sexual violence, prior to April 15th, more than 3 million women and girls were already at risk of gender-based violence. The number has since climbed to a grim 4.2 million people. These statistics serve to further illustrate the connection that Sudan's particular demographics previously highlighted will lead to targeted solutions and different approaches. Next slide. So what are our challenges as we venture into humanitarian health here? I caveat this, that this list is by no means meant to be exhaustive, but simply one slice of a multitude of layers of challenges, given this, the backdrop of this conflict. There are two umbrellas which we've grouped this under. The first being limited humanitarian access. So safety and security. There are no clear demarcations or delineations of conflict as a result of urban warfare in Khartoum. This considerably intensifies the complexity of the last mile delivery. Currently, 9 states are accessible, 3 are partially accessible, and 6 are not accessible at all. Add to that disrupted health services. Amid a backdrop of protracted economic crisis and pre-existing conflict, as well as deteriorating systems, we know that 1/3 of the population was in need of humanitarian assistance even prior to the crisis. Currently, less than 20% of health facilities in high conflict areas remain fully functional. Compound that with the looting of humanitarian assets, including IRC-specific warehouses and offices, destruction of critical infrastructure, and impediments to safe water and services, and we find increasingly high safety risks for women and girls. Operationally, there are extensive customs import clearances necessary, and initially national government systems were non-functional as they were based in Khartoum, which was essentially in a security eclipse and on lockdown. Now many have relocated to Port Sudan, but initially this did cause some delays in customs clearance. National government systems were essentially halted during that time. Next slide, please. So a strategy to deliver in Sudan. Localization as one of many solutions. I'm going to magnify a few particular strategies, and of these strategies, localization is, again, just one option, but there are many options, and this is not meant to be exhaustive or a panacea of any kind. I want to acknowledge that there are many different ways to serve the needs of the community given the complexity. So the IRC is engaging community partners to reach patients in inaccessible zones, especially in volatile areas like Khartoum, by doing some of the following. We support community groups who drive women in labor or with pregnancy complications to health facilities or connect them with midwives and gynecologists. We support local organizations that deliver essential medications and services to neighbors. And these local groups also at times cover staff salaries, provide accommodations and meals for pediatric oncology patients. This is a hyper-localized approach in Khartoum in particular due to the access constraints, almost down to neighborhood by neighborhood and block by block. And the reason it works is because we know that these local organizations have already engendered community trust. They have access to otherwise unreachable areas, and it works because we trust that the local actors can address their own community's needs best. Additionally, IRC supports the existing health system to address disruptions in services by engaging directly with district-level authorities. While the National Ministry of Health might be overextended, we work in concert and with and alongside ministries of health, deepening our relationship with them to deliver needs-based services and ensure there are not duplication of services while still strengthening local capacity. Examples of this include conducting joint needs assessments to inform programming with local staff and authorities, providing training, for instance, in community management of acute malnutrition, and supportive clinical supervision to build the capacity of the existing staff and meet the needs of the population. Next slide, please. So here's where we are now. The IRC provides an integrated health, nutrition, water, and sanitation program, and also provides child protection services and comprehensive women and girls protection and empowerment services, including to gender-based violence survivors. We support 8 health facilities in Wad Madani, a host community seeing a surge in IDPs, 9 health facilities in Gedaref, and 21 in the Blue Nile. We can see here by the data presented, once again, that the data threads the needle through the demographics of the population previously reported and their respective needs. It's highlighted earlier in the talk with the majority of services that are consistent with the demographic identified, which is pediatric or a younger population in general, inclusive of immunization and nutrition services, with over 44,000 patient consults outpatient conducted since May 28th. And we can see nutrition, vaccine, SRH, and other concerns taking precedence in these numbers reflected here. Next slide, please. So moving on to our next conflict, here we find ourselves. It's February 24th, 2022. Russia invades Ukraine, resulting in large-scale civilian casualties, damage to health infrastructure, supply chain disruptions, which are compounded by health staff attrition due to military conscription enforced under martial law. Over 17 million people require urgent humanitarian support, including more than 5 million internally displaced by the war. Our snapshot here shows that there are 5 million, as we noted, internally displaced, and over approximately 6 million refugees externally in European countries, with approximately 47% of funding allocated, compared again to the previous approximately 30 to 31% in Sudan. Our population in need are often internally displaced persons fleeing west. Those who are unable to leave often shelter in place in hard to access areas. This includes people with disabilities, elderly, pregnant, and lactating women. According to needs assessments of non-displaced households, approximately 48% reported of respondents were greater than 50 years old. 37% had a member of their household who was chronically ill. 56% of IDP households had members traveling with them greater than 50 years old. Again, the demographic connect the dots for us as we identify health needs which are largely exacerbated non-communicable diseases due to disruptions of health continuity, monitoring, and medication, inclusive of cardiovascular disease, hypertension, diabetes, thyroid illness, chronic illnesses, TB, HIV, and hepatitis, which I'm sure ICAP is working on as well. And I'd be very interested to learn more from Oksana as she could speak to that, as well as mental health and SRH specific to perinatal and clinical management of rape. Keeping in mind that our health systems here are markedly different. This is a middle-income country with a robust national health system in place, and it's a highly centralized system with national and oblast ministry oversight. IRC is continuing to work to destigmatize and integrate mental health into our primary care, as well as gender-based violence. Next slide, please. So, delivering healthcare near the front lines. We've outlined here some opportunities and some challenges, but before we do that, I'd like to hone in on the attacks on healthcare. Over 1,000 attacks have been documented to date. Some opportunities presented. The supply importation under martial law is actually less cumbersome. In this case, it's working in an international NGO's favor, as some of the more bureaucratic processes are foregone due to the state of emergency. Being a middle-income country, there are highly qualified staff available to work, highly motivated, and many are IDPs themselves. The national and oblast ministries of health and a multitude of international NGOs have enhanced coordination amongst ourselves to deduplicate responses. The responses funded at approximately 47% versus 31% in Sudan, which all of these present a unique opportunity for international NGOs to have an abundance of stakeholder supplies and coordination, as well as some access. The challenges, here we see obtaining access to the remaining populations near the lines of aggression, where even local ministries of health and infrastructure and networks have been shattered beyond recognition. We pay special attention, in this case also to winterization, where blackouts and lack of fuel contribute to the fractured response services. Operating where static health facilities and critical infrastructure has been completely demolished is, of course, a challenge we recognize. Key specialty services, as alluded to before, remain centralized, requiring referrals, and thus requires more social and community coaching to a survivor-centered approach, as opposed to a mandatory reporting of sexual violence. We continue trainings on mental health and clinical management of rape in order to destigmatize. The nature of the diseases, such as NCDs, require sustained continuity and lab management and monitoring to our patients in order to manage chronic illnesses, specifically in elderly and perinatal care. Next slide, please. Just one solution to deliver in Ukraine is mobile health, which has seemed to work well for us. The IRC supports 3 health facilities and runs 1 IRC direct implementation mobile unit along with 4 partner-led mobile units. So who are the partners? We support local mobile vans organized initially by a loose group of IDP doctors and nurses who got together and decided that they wanted to serve their populations, had essential medicines and health supplies with initially their own vans and driving into newly accessible, very dangerous areas where even ministries of health and others were unable to access. And we're providing primary health care, NCD care, as well as some perinatal care. We support the local doctors and nurses. Again, they know their communities and have already engendered trust for that. What we've instituted now is integrated that with mental health and protection services to serve the needs as a one-stop shop for our patients. So we identify and transport high acuity, high complexity patients requiring referral to secondary facilities and conduct mental health, clinical management of rape, and other such trainings at health facilities. And the photo to the right is one I took of children playing in a bomb shelter in Ukraine here. So the next slide, please. So what are these solutions, or where are we now? I'd like to highlight here, let's walk through this map together. Looking at the clearly demarcated lines of aggression, we see several areas that used to be or are inaccessible to services. The green highlights newly accessible areas, and the black and white shaded region is where IRC has areas of health intervention. Now, if you consider what those areas might look like if you were to walk down the neighborhood, blackouts, extreme cold, no fuel, people sheltering in place who could not leave, including caretakers of the elderly, remote areas that have been shattered and reeling from war and PTSD at the front lines. Now look and see how close IRC was able to get. And you can see the overlap of the black and white shaded regions and the green, and even the black and white shaded regions that are so close to the red lines of aggression there. Specifically wanted to call out areas in Kharkiv and Mykolaiv, and where we have mobile units serving people who would otherwise be isolated and unserved. And here we see the demographics again, tying to the prior information, indicating that again, we're seeing NCDs as the majority of the population's needs. The demographic is largely female, older than 50, and you can see that SRH, mental health, and NCDs remain in need. And now I'd like to transition to my colleague Elizabeth, who will walk us through some longer-term system shifts to offer some solutions during protracted crises. Thank you so much for your time.
Thanks very much, Seema. Seema's done a fantastic job of walking us through some conflicts that are really in their acute phase. However, I'd like to talk about the case of protracted conflicts, which are increasingly the rule, not the exception. The map that I'm showing here is from IRC's 2023 watch list, which is our projection a year out of the countries and contexts that are most likely to experience severe crisis. And the point that I want to highlight here is that among these 20 countries, the average duration of conflict is 12 years. Next slide, please. This means that we need not just the type of urgent, effective emergency response in the acute phase that Seema was speaking to, but we need systems change solutions that can deliver and continue to deliver in contexts where we're likely to see chronic disruption, often over a period of years. For today's presentation, I'll zoom in on two systems changes where we see potential. The first is a simplified, decentralized approach to treating acute malnutrition that's really tailored to the conflict disruption context. And the second is an effort to pivot to a much greater engagement of civil society to deliver immunizations to people that governments cannot or will not reach, and those are primarily in conflict contexts. Next slide, please. So to look at the first problem, which is the acute malnutrition treatment gap, I'll highlight that acute malnutrition is the most deadly form of childhood malnutrition affecting children ages 0 to 5. Analysis of historical cohort data tells us that the most severe form of acute malnutrition is associated with an 11-fold increase in the risk of death. Acute malnutrition is common in conflict settings. For example, this year, it was projected that up to 50% of children in Somalia may face acute malnutrition. The good news is that treatment using a fortified peanut paste is highly effective. The problem is that only about 1 in 5 children have access in conflict settings. To drill down on that statistic a bit more, I'm presenting a graph here from a piece of work that I think may resonate with some of my former ICAP colleagues. So at the IRC with our Ministry of Health partners, we conducted population-based coverage surveys to look at the coverage of severe acute malnutrition treatment. This was done in 15 conflict-affected districts in Africa. The results are pretty sobering, ranging from less than 1% in Mudug, Somalia, to up to 45% coverage in Baro, Chad. I'll highlight that 11 of these 15 districts had less than 20% coverage. That's less than 1 in 5 children accessing this life-saving treatment in conflict settings. Next slide, please. Our theory on why this is the case, on why it has been so difficult to extend that life-saving treatment, is that the traditional approach is unnecessarily costly and complex. And we've sketched that out in the left-hand panel here. The traditional approach to acute malnutrition treatment is based on a complex weight-based diagnosis and a complex weight-based dosing formula that it divides the condition of acute malnutrition into 2 forms: severe acute malnutrition and moderate acute malnutrition, that are treated through 2 different protocols using 2 very similar but distinct treatment products, each requiring their own supply chain, each managed by a different UN agency, UNICEF and World Food Program respectively, and finally delivered at 2 different points of service with long distances to access treatment, and confusion about which point of service is right for each child. In replacement of that, we've come up with and proposed, colleagues at the IRC have proposed a simplified approach, which uses a simplified diagnosis and dosing, 1 upper arm measurement as the diagnosis, and a simple dosing that provides 2 packages of treatment for severe cases and a single package for moderate cases at a single point of service. It's a single treatment product. And the aim is to decentralize care as close to home as possible, including out of the facility to the community health worker level. Next slide, please. So that's the theory. And of course, we need the research to know if this is in fact an effective and efficient approach to roll out, particularly given how vulnerable the patient population is. Colleagues at the IRC, again with Ministry of Health partners and with additional civil society partners, carried out the COMPASS trial, which was a 4,000 patient randomized controlled trial in South Sudan and Kenya. finding that the simplified protocol was non-inferior, or at least as effective as the standard, more complex approach. We then went on to test this in a larger, longer running operational setting, and our operational research with over 90,000 children in 5 countries found recovery rates of 85 to 95% among children treated with the simplified combined protocol. That's far in excess of the 75% recovery rate, which is the Sphere humanitarian standard for malnutrition treatment. And finally, I'll zoom in on one context in particular, which is Nara, Mali, a conflict-affected district where we ran a prospective cohort with over 40,000 children, and found that in addition to being effective, treating a severely wasted child using the simplified protocol was efficient. It cost 24% less per child. It used 40% less treatment product per wasted child, and it was feasible to deliver through community health workers, achieving a remarkable 94% recovery rate when delivered by community health workers. Next slide, please. So these are the findings that have encouraged us to promote a systems shift from the traditional, more complex bifurcated approach to this simplified, streamlined approach. We found it effective at recovering even the most vulnerable children, cost effective compared to the standard approach, requires less treatment product, and the treatment product is often in short supply and a bottleneck. The simplified protocol is feasible to deliver through community health workers, even in disrupted and conflict settings, and even those with low literacy. Additional work was done on that in Sudan and South Sudan. And finally, my own editorial that I hope will resonate with this audience. To me, it was really striking that this simplification was quite analogous to the public health approach that simplified and decentralized HIV treatment, leading to the really remarkable global scale up that we've seen in that space, and that ICAP, and I'm sure many on this call have been leaders in. Next slide, please. I'll turn now to the second challenge, which is that immunization coverage globally has plateaued. This is a graph showing global immunization coverage by antigen between 1980 and 2019. There's quite a bit of information in this graph, but the main takeaway that I want to highlight is that there was an initial very rapid scale up of immunization coverage, and then a somewhat slower scale up over the 90s and 2000s, leading to what's really been a plateau in the most recent decade, particularly for important childhood vaccinations, including DTP, diphtheria, tetanus, pertussis, as well as MCV, measles-containing vaccine. Next slide, please. One of the reasons that poor coverage persists is that in areas beyond government reach, we've seen consistently low immunization rates. This is especially true in conflict zones. That's been the barrier that has really caused the global scale up to plateau, the persistent inability to reach these populations. Here I'm presenting some baseline data that bears this out from the Gavi Reach Consortium, which is an IRC-led non-governmental alliance to expand vaccine access in conflict-affected zones of Ethiopia, Sudan, South Sudan, and Somalia. So in the 156 operating districts for this program, there's a population of 2.2 million children under 5. We've estimated that over 1.2 million of those children are what we call zero-dose children, meaning they haven't received a single immunization. As an indicator, that's measured by not having the first DTP vaccine. An additional 420,000 children are under-immunized in this setting. So this means that while global immunization rates are around 80%, and in many contexts in excess of 90%, well over half of children in these disrupted, conflict-affected settings are not sufficiently immunized. When we drill down a bit on what is this population, what does it look like, we see that more than half of these districts are not under government control, or only under partial or are under no government control. And in terms of population characteristics, again, well over half, in fact, almost 3/4 are IDPs, internally displaced people, or refugees, people who are moving because of conflict. So the challenge is that the global immunization effort has been rolled out largely through governments, with governments in the lead, under government strategies, and that's entirely appropriate. But the argument is that we need to pivot to additionally layer on civil society and non-governmental engagement to be able to reach these populations that are not feasible to reach through government programming. Next slide, please. And so here are some of the strategies in progress that we've seen through the REACH program, which is in its first 6 months of operation. The international NGOs, as well as local civil society organizations in the coalition, have been leveraging their position in civil society to negotiate humanitarian access with both governments and armed groups. The non-governmental actors are in a unique position to speak to both sides here. We've been working on optimizing delivery locations by launching mobile and cross-border campaigns that can extend traditional government campaigns, informing those with analysis of GIS and population data to figure out where we can reach the most people at the right time. And finally, gathering client feedback and really hearing from the communities to design non-traditional client-centered approaches. For example, not just co-locating additional health services with the immunization services, but also providing immunization for livestock at the same place we're providing it for children, thereby marrying the health and economic incentive as well as the health and economic benefit. And the initial progress in the first 6 months, I'll call out a few notable things here. Along with critical shifts in the political context, and notably the Tigray peace agreement in Ethiopia, access negotiations with NGOs have reduced the inaccessible areas from 43% of those 156 districts to 13%. And on the whole, they've delivered almost 300,000 doses of critical childhood vaccinations. Next slide, please. So in the last minute here, I'll just wrap up and say, I think we've taken you on a whirlwind tour of challenges and solutions for public health in conflict settings. But if there's a few points that we'd like to leave you with, it's these. The first is that rising global conflict has a devastating impact on health outcomes and health inequities. Of course it does. But there are solutions to deliver and safeguard health, even in the most challenging settings. We stand a real chance at improving health and reversing inequities by fine-tuning, studying, iterating, and ultimately scaling these solutions. And then I'll leave you with a maxim that we like at the IRC, which is that we take action to drive the hope rather than relying on hope to drive action, and that we're always looking for partners in action. Next slide. Thank you very much for inviting us today. It's a real pleasure and an honor to be back in the ICAP orbit, and I look forward to your questions. Thank you very much.
Okay, well, those were just wonderful talks. And let me first, just since I had a problem with my microphone before, just make sure people can hear me. Is that all right?
Yes.
Okay, wonderful, wonderful. Okay, so let me just pose a few questions that our audience has put to our speakers. And the first one is from Koso Meli. Sorry. How are these conflicts affecting people living with HIV and TB? And I believe that's a question really for Dr. Oksana, because the question refers to reports of bombed hospitals in Ukraine. And the second question is about medical supplies, supply chain, and difficulties with managing drugs and reagent stockouts. Maybe Oksana, you can touch on that briefly, and then hopefully allow time for a quick response from either Seema or Elizabeth.
Yes, thank you, colleagues. Thank you for this question related to this particular two diseases. First of all, as we have this conflict started from 2014, and looking for the escalation possibilities and during the winter period before the February 2022, the most of the facilities have been evacuated on the western part of Ukraine. So there's not a huge number of patients, but it's still a very, very important step in order to organize and to preserve people from having these troubles. As for the, now we are talking about the area which is in the eastern part of Ukraine, which is out of government control. So there is no information how the patients are living here and receiving the treatments. But as for the government control area, it's more or less organized based on the humanitarian help organized by the donors, like IRS, International Committee of Red Cross, WHO, European Bank, and some other organizations. So they are not only delivering the remedies here in Ukraine, they're also distributing into the healthcare facility and having this very, very well-established contacts with administrating to receiving the purchase and restock necessary remedies. As for the support from the Ministry of Health, we definitely organize this is help feedback and this dialogue. We haven't understand and haven't submitted all together based on the health cluster approach, who are from the donors going to enter and to donate some remedies in the territory of Ukraine, in particular health facility, and this registered on the Ministry of Health files, shared on a monthly basis and very well coordinated. So it's not, how to say, a huge help, but at least this is what we can do from this humanitarian response support and area focusing on these challenges. Thank you.
Yes, I wouldn't have too much to add to that. I think, Oksana, you really captured that well, except to say that there was enhanced coordination because it is quite a high-profile response. And yes, there certainly were disruptions and continue to be disruptions in supply chain. However, again, in working in coordination and alongside the ministries of health, both at the oblast level and on upward toward Kyiv, has really helped the coordination efforts. One thing that I found interesting in this particular context was health facilities having a very strong understanding of their needs. And because it is a high profile response, sometimes what might happen is people with well-intentioned organizations be donating all kinds of medical supplies, and yet at the health facility level, sometimes they would say either this is not useful, this is not necessary, and then they would have a very targeted list, which I found helpful as we planned our response, but also eye-opening in a way of when there is a surplus and robust response and a surplus of supplies, how are we managing that? Are we targeting our response specifically to the needs identified in the population? I hope that answers that.
Great, thank you, Seema. Wafa, I think you have a question.
Yeah, first, thank you all for really wonderful presentations and very insightful. I have a question, and I'm sure you've had to tackle this, everybody on the call, all the speakers, but you know, this, based on experiences that certainly we've had in terms of working with Syrian refugees in Jordan and Turkey and Lebanon, and there's always the tension or potential tension between displaced populations and host populations. And I'm wondering if any of you can give and comment on, I guess, how do you deal with that tension, and how do we pay sufficient attention to host communities and their needs, while at the same time focusing on the acute needs of the displaced populations?
Shall I defer to Dr. Oksana, or anyone else who'd like to take that?
Go ahead, Seema. Go
Okay, thank you.
Go for it.
I might ask you in your vast experience, actually. It's a very, very, very good question, and it is pertinent in both the context of Sudan, who's been a longstanding host, I believe, of, again, over 1 million refugees prior to the conflict, and has chronic conflict as part of their tapestry. And then also in Ukraine. There can certainly be, and often is, that tension between, let me specify first for Ukraine, in the mobile health clinic arena, because we are targeting areas that are either newly accessible or very difficult to be accessible. Those tend to be host communities. So I think it comes down again as a merger of the two ideas of mobile health and localization, is if we're working alongside partners, we're demonstrating goodwill and good intention and deepening our relationships to show that we are here to serve whomever is in need, not just one population or another. So not only IDPs and not only hosts, and certainly the mobile health clinic, we've learned is specified to the host community as people who could not leave and would otherwise not get those services. Sudan is the flip side of the coin. We see, for instance, Khartoum, a large exodus of people from Khartoum into neighboring states, specifically Wad Madani, where we have new services available there. I have not been to Sudan in this context. I've been in other contexts, and I do notice that tension. However, in this instance, I am also noticing that is such a dire situation, and it has protracted over so long on this tapestry of conflict and need, that as long as we're demonstrating that we're not, as an NGO, preferential, that we're here to work with anyone, then I feel that does serve to go a long way, but also really working even alongside, but just supporting the existing infrastructure and supporting the existing local partners. Specifically, I see in Khartoum as these local neighborhood areas where they already have engendered that trust. They've already they're community leaders that are trusted already. So we're able to harness that and leverage that.
Okay, I think we are down to our last 2 minutes. None of the questions that come in really, I think, are going to lend themselves to extremely brief answers, but there is a question about whether IRC supports logistics for nutrient health product donations. I don't know if that's something that's as simple as, information that's on the IRC website about how to support health product donations, but I'm thinking that this might be a quick one.
We can certainly share a website, which might be easier. I'm trying to see if this was specific to Ukraine or Sudan. Yes, we can certainly share a website where the donations division can certainly do the appropriate vetting and see what's targeted to the population. I think that might be easier and quicker, but yes, we do support that. Although we consider a health programming much more than simply donations. We hope to strengthen and fortify the systems in place as opposed to only donations, but that's certainly a portion of our programming.
Okay, I'm hearing that my microphone is still causing problems. I apologize, and we'll have to check that out. If we can squeeze in one more question. We did have a question about whether chronic diseases and care for chronic diseases is an area that IRC is able to pay attention to. And again, that needs a quick reply. And then I think we'll have Dr. El-Sadr wrap up, just given my microphone challenges.
At this time, in terms of chronic illnesses such as hepatitis, HIV, and TB, that's certainly a need that's been identified in both populations. I would actually defer to our ICAP colleagues here, as the IRC is concentrating, at least in the Ukraine context, on non-communicable diseases in terms of diabetes, hypertension, thyroid, and longstanding illnesses. So I defer to Dr. Oksana in that realm. And then again, in Sudan, it would be the malnutrition and chronic illnesses as well as SRH.
Seema, I would just jump in and say that one of the reasons I think we highlighted the mobile approach in Ukraine was that was an approach that was well aligned with the need for ongoing chronic disease care, NCD care, knowing that a sort of one-off campaign and immunization style campaign wasn't going to meet the needs of the patient population that needed chronic care. We needed a way to continuously get in on a regular basis and see clients that needed regular monitoring and support. Those NCD clients, kind of chief among that profile.
Exactly
let me pause
right.
there since I know we're over time.
Well, I have to say this is express my appreciation to all of our speakers today for a very, very important insights that you provided. I think this topic is very, very important. And as many of you have said, the situation is protracted and there are many, many challenges that continue to be faced by the global community in trying to tailor the responses to the needs in various parts of the world. As Jessica mentioned, this webinar has been recorded, and both the recording and the slides will be posted on our ICAP website. And want to invite you to our next Grand Rounds webinar, which will take place on October 17th at 9 a.m. Eastern, and that will be focused on violence against children survey conducted in Eswatini. Thank you again, and thank you for your enormously important work. Have a good day, everyone.
Thank you so much.